Hi guys, welcome back to the channel. My name is Dr. Downey, and today I am finally releasing the Halotestin video that I said I would release probably about 6 months ago, if not more. I'm really sorry I haven't been posting much this year. It's been a very busy year for me career-wise, so I hope you'll be able to forgive me. So anyway, here is the video on Halotestin that I promised I'd bring out. So in this video, we're going to look at halotestin as a drug, look at how it works, look at a few studies. Obviously, studies are limited. And then from there, we will try apply it to the average steroid user. And now, just as a disclaimer, yes, I am a doctor, but none of this is medical advice. So halotestin, or excuse my pronunciation, fluoxymesterone, is essentially a testosterone derivative. There's a bit of contestation around its half-life. Some people report it being around 9 hours, some other papers report it being 6 hours, and then there was one paper that looked at buccal administration where you put it in, well, it's essentially absorbed by your cheeks, and that was 2 hours. So there's a bit of a mix here, but overall, it just has a short half-life. That's all that matters. Just like most oral steroids, it is metabolized by the liver and it is reduced by 5-alpha reductase. For those who don't know, 5-alpha reductase converts testosterone to DHT, and in the case of halotestin, it converts it to a metabolite called dihydrofluoxymesterone. There aren't too many studies around this metabolite, but we'll get into that just now. What's interesting about this compound is that it is hydroxylated at the 11th carbon atom. And what this hydroxylation is thought to do is slow down its aromatization into estrogen. And this is supported by a few studies that show that halotestin doesn't easily convert to estrogen or bump up serum estradiol levels. Furthermore, as you guessed in the name, it's fluorinated. And this fluorination, similar to the chlorination of turinabol or T-bol, is also supposed to prevent conversion into estrogen, as well as it increases its ability to be absorbed via fat. This is important because it means it has to be bound to a protein when circulating through your blood, and it also means that it easily crosses through membranes, cell membranes in particular. Furthermore, the fluorination helps with its bioavailability. What this means is that it helps with increasing the amount that is absorbed when you consume it. And it's supposed to help with its metabolic stability, so slow down the metabolism by the liver or 5-alpha reductase or aromatase. Halotestin was one of the first anabolic steroids that was looked at for purposes of enhancing growth. So there are a few studies that were done in children, and it was probably one of the first androgens that they looked at that actually improved epiphyseal function, or essentially growth plate function. And this might be due to the fact that it doesn't aromatize, because as we know, estrogen seems to close those growth plates. So what's its effect on prolactin? Well, like with most androgens, it actually decreases prolactin levels or inhibits its function. We don't know whether or not it decreases the levels or it antagonizes the function of prolactin, because these studies more or less look at endpoints. For example, a lot of the studies would look at women who are lactating excessively, and they would administer this drug, and this would prevent lactation. And some presume that's due to a decrease in prolactin, but it could be due to other effects. However, this effect is not unique to halotestin. Testosterone used to be used prior to the introduction of bromocriptine and other prolactin antagonists. So it's quite a common characteristic that most steroids share. So when looking at how androgenic it might be, we can look at studies that were conducted in women, because We know that testosterone given to women causes virilization, which is essentially secondary male characteristic development, such as facial hair, labia thickening, things like that. And in the study, what they did was administer 20 milligrams to 30 milligrams of halotestin to women who had experienced virilization on testosterone, and they found that when they swapped this testosterone propionate, which was 150 milligrams to 250 milligrams weekly, that the virilization improved. So this could potentially imply that it's not as androgenic as testosterone. However, I would say its effects are more selective. In this small study, they didn't show an increase in blood pressure, abnormal weight gain, or any of the usual side effects you get with most androgens. What they also failed to show, which is interesting because most androgens help with osteoporosis, or at least preventing its progression, is that it didn't improve bone density. Now, this isn't very surprising because it doesn't convert to estrogen, and estrogen is known to help with bone support, which is why a lot of women who have breast cancer taking something like tamoxifen or Arimidex tend to take vitamin D and calcium supplements alongside. However, in those who had osteoporosis secondary to corticosteroids, or what we know as cortisol, this actually prevented progression. This is interesting because it suggests that it might work against cortisol. Now, we don't know whether it decreases circulating cortisol levels or it just blocks the action of cortisol. I would argue it's the latter, and I'll show you now why I think that is the case. What's interesting, though, with its androgenic effects is that, or lack thereof, is that when used in males, the results were not as satisfactory as using something like testosterone, because the males complained that there was no increase in libido, no improvement of facial hair growth, or any other of those androgenic effects that most steroids have. And this again kind of suggests that it's probably not as androgenic as testosterone. Now, an interesting effect that I wanted to look into, because I think there were a few claims that halotestin doesn't really cause suppression, or it doesn't interfere with fertility. It was one of the two, probably the latter, because there's a bit more research on halotestin and fertility. And again, it's interesting, but I am never going to make a medical recommendation on research as weak as this. It's just out of interest and for entertainment. And obviously, I encourage you to think of it in the same way that I do. The research isn't very strong. There's not a lot of population data, so clinical utility is minimal, but interesting nonetheless. So in this study looking at suppression, they gave men halotestin 10 milligrams every 6 hours, so approximately 30 milligrams a day, perhaps 40 milligrams. And what they found is that it displaced testosterone from SHBG, which we do know does occur when given anabolic steroids, and this effect was dose-dependent. And as you might assume, through the displacement of this testosterone, there's more circulating free testosterone, and this suppresses LH secretion. So luteinizing hormone is important for intratesticular testosterone production, and that decreased. And this happens with most steroids. And eventually, after 4 to 5 days of treatment, LH levels were undetectable, which basically means they are completely suppressed, or some people say shut down. But that isn't really surprising. And this effect is usually dose-dependent and dependent on your duration. But what is interesting is looking at the effects of halotestin on testicular function, more specifically on sperm. So what's very interesting is that halotestin doesn't really interfere with sperm counts. However, again, there's a bit of mix in the literature. But after this one study, they looked at an administration of halotestin at different doses for 16 weeks. And there wasn't a statistically significant drop in sperm count. However, there was a drop in sperm motility as well as testosterone. The effect on testosterone is something we already know, it's suppressive. LH levels also dropped. However, FSH levels did not change. Now, this is interesting because most anabolic steroids will suppress both luteinizing hormone and follicle stimulating hormone at the same time. Now, follicle stimulating hormone is more important for the development of sperm. However, both luteinizing hormone and follicle stimulating hormone both work together in sperm production, but FSH is a bit more important. And this could show why sperm counts did not decrease, however motility did, as luteinizing hormone and androgens are a bit more important for sperm motility. But as I mentioned prior, the research is a bit mixed because they found in a separate study that a dose or higher doses do cause azoospermia, which means no sperm being detectable. And this occurred within 3 to 6 months of starting treatment. And the dose that this occurred at was 5 milligrams. However, they realized that at lower than 5 milligrams a day of halotestin, that sperm counts actually improved in these men that had sperm counts that were not optimal. But there is that confounding factor or variable that these men were subfertile before, which is possibly why higher doses caused azoospermia. Because as we note in the study I just referenced prior, this was in normal men, and there wasn't really a drastic change to the sperm count. It is important to know that at higher doses, there is a higher chance of infertility as well as, and the effect of androgens on fertility is also duration dependent. Now, I have made a video about this, and it's how it inhibits 11-beta HSD, or hydroxysteroid dehydrogenase. And this particular enzyme is important for inactivating cortisol. So in theory, halotestin should increase cortisol levels, but as I just mentioned prior, in the one study, it actually halted progression of corticosteroid-induced osteoporosis. And this is what I have come to realize is quite common with steroids. They increase cortisol levels, however, they have this glucocorticoid receptor or cortisol receptor antagonism. But that's a topic for another video. It's not really antagonism, I would argue it's partial agonism. But that's more pharmaceuticals, and touch on that in a different video. It's a bit more complicated. So in terms of halotestin and its effect on hematocrit and hemoglobin, it does increase hematocrit levels, and this was noted at a dose of 15 milligrams daily. What's interesting though, most oral steroids increase triglycerides, however, halotestin decreased those serum levels. So there was a study that looked at using halotestin to replace testosterone in males who were on TRT. What is interesting to note is that at a lower dose of halotestin, it was able to maintain prostate and seminal vesicle weight. And this is interesting because usually that relates to a drug's androgenic potential, which is why I say that it might be selective in some areas and non-selective in others. The dose required to effectively replace testosterone replacement therapy, so a lot of these males were on 30 milligrams of testosterone propionate a day. What was needed to maintain their weight and symptoms was a dose of around 2 to 3 milligrams of halotestin per day. So this is very interesting because it suggests how potent halotestin is at a lower dose. There was another case series that was done in males on TRT, and they were switched to 5 milligrams of halotestin daily for approximately 6 months. And what they all noted was that they had superior improvement of symptoms as well as body weight, musculature, and this was continued for 2.5 years, so 2.5 years of just using Halotestin. And after the 2.5 year point, there was a significant dropout. However, they noticed cholesterol increased, which is a usual effect that oral steroids have. But other than that, they didn't really look at many other parameters, and I would have been interested to see things such as liver function tests, but a lot of these studies are old, and a lot of what I'm saying is just out of interest. So we know that oral steroids are quite toxic to the liver, and I couldn't really find many studies looking at halotestin and its effect on the liver, especially in humans. But there were a few studies that looked at halotestin in rats, and what they showed was quite a significant amount of hepatotoxicity. What they saw was that the hepatocytes or liver cells, their membrane was disrupted, and this could be due to the fact that halotestin is quite lipophilic, so it easily crosses the membranes, and in doing so it might disrupt the membranes, or this could be a secondary effect of increased free radicals, which cause disruption. And as we know from a lot of anecdotal data, halotestin does seem to cause similar liver toxicity as other oral steroids. Now, what was interesting in these rat studies, and something that's spoken about a lot, is that halotestin causes a lot of aggression, and the thought process behind that might be due to the fact that it more readily crosses in through the blood-brain barrier. And, well, that makes sense because it's fluorinated, which means it easily crosses the blood-brain barrier. And in these rat studies, they found a lot of halotestin inclusions in white matter, the white matter of the brain. So that's important to take note of. We don't know the clinical relevance, but there could be an element of neurotoxicity there. However, we don't have enough data to say so. So, in summary, it does seem to be more anabolic than testosterone is at a milligram per milligram basis. It doesn't seem to cause as much of a spike in estrogen as testosterone does, as well as it doesn't appear to cause androgenic side effects. In terms of its suppressive abilities, there's nothing at this point in time to suggest that it's less suppressive than other oral compounds. It seems to have a similar ability to cause suppression as other compounds with shorter half-lives do. What is interesting, however, is the fact that it doesn't suppress follicle-stimulating hormone. And this could be the reason why some people say it doesn't influence your fertility as much. From the limited research we have, this does seem to be the case. However, I wouldn't try put it in practice. So let's look at a halotestin-only cycle. As mentioned previously, most of the research I looked at was actually in participants using halotestin only. There seemed to be good improvement of hypogonadal symptoms at a dose of 2 to 5 milligrams per day, and this was used for a 2.5 year duration. However, the sample size was small, there was a lot of dropout, and I wouldn't do anything based on these results. There's not enough population data to assess its clinical utility in the realm of testosterone replacement therapy. But let's say you were doing a oral only cycle and your drug of choice was halotestin. It still has the ability to convert to estrogen as it is a testosterone derivative, but because it's fluorinated and has that change at the 11th carbon atom, it doesn't seem to be readily aromatized, meaning it doesn't cause as much as of a peak in estrogen. This might be beneficial in someone who is extra sensitive to estrogen but doesn't want to crash their estrogen levels by using a drug that isn't converted to estrogen at all. Furthermore, it doesn't seem to be as androgenic more specifically in terms of virilization, which means it could be safer on the hair for someone who is prone to male pattern baldness. Its anabolic capabilities do seem stronger than testosterone, however, we don't have a lot of data looking at muscle gain. So it potentially could be used as a drug by itself in a cycle. But there are a lot of concerns. We don't have a lot of data on its safety. We know that it might not cause as many issues with fertility. However, again, this wasn't compared to other androgens. It was a small trial. It's definitely not enough data to make sweeping statements about how safe it is on your fertility. There is a potential for neurotoxicity as well as increased hepatotoxicity. There was data showing that it does increase your hemoglobin levels as well as cholesterol levels. There is the concern about it interfering with 11-beta hydroxysteroid dehydrogenase, which could cause spikes in blood pressure or cardiac issues. We don't really know. The effects haven't been fully assessed in high-quality trials. And that's why I'm always very conservative. Until there's good research, I'm not going to say much on that. Again, this was just out of interest. And I'd be curious for those who have tried Halotestin, what were your experiences like? Is the aggression from it as common as they say it is? What side effects did you get? Do you have blood work showing that it caused deleterious side effects? I'm just interested to hear from you. And I hope this video was entertaining and educational, and I am sorry for being MIA for so long, and I hope to produce more content in the future, but thank you so much for watching, and I'll see you all in the next video.